Yes, okay. Please start.
Yes. Good evening. So I'll be presenting a case on a ciliary body mass. So the case was a 17-year-old male who presented with a left eye redness and mild pain for 15 days. And there was neck swelling associated for since the last 20 days. There was no history of TB or TB contact. And there was no history of fever, breathlessness, joint pain, skin lesions, or GI disturbances. So on the anterior segment examination, we saw inferior sectoral scleral congestion. And on 90-day examination, we saw a dome-shaped lesion, which was seen at the site of the ciliary body. On systemic examination, there was presence of neck swelling. And on the fundus picture, the disc and macula were normal, but there was inferior focal vasculitis. And on the B scan, we saw a dome-shaped mass, which was present on the transverse and anterior and inferior quadrant. And on ultrasound biomicroscopy, there was a dome-shaped ciliary body mass, which was at the inferior quadrant, and it was homogeneous. So we made a diagnosis of differential diagnosis of ciliary body granuloma, ciliary body melanoma, ciliary body epithelioma, and ciliary body secondaries from thyroid or parathyroid gland. And we went ahead with investigations. On the investigations, we found that the ESR was raised while the Mantoux test was negative, and the TSH and thyroglobulin and CRP were also raised. So we asked the patient to go to a physician, and he advised ultrasound thyroid, in which it was seen that there was an adenomatous goiter with cystic swelling, while on the fine needle aspiration cytology, there was a gross specimen pus-like fluid, and acid-fast bacilli was seen, suggestive of a tubercular abscess. On the cytology, there were polymorphs, lymphocytes, and macrophages with a caseated necrotic background. And on HRCT chest, there were diffuse tiny miliary nodules in all lobes of both the lungs. So we made a diagnosis of left eye tubercular ciliary body granuloma with miliary tuberculosis, and we started the patient on anti-tubercular drugs after approval from the physician. So after 15 days of presentation, the patient came to us on follow-up, and the inferior sectoral congestion was still present. On 90-day examination, on the primary visit, there was only one lesion, while on the second visit, there were multiple ciliary body granulomas inferiorly. As we can see at presentation, there was no disc edema, but after 15 days of follow-up, when the patient was on ATT, there was disc edema. And inferiorly, there were two ciliary body masses which were shadowing in the inferior part of the retina with inferior focal vasculitis. So even on the OCT, there was optic disc edema. On the B scan also, the size of the lesion increased, and on ultrasound biomicroscopy also we could see that the size had increased after initiation of ATT. So we thought of it as a paradoxical worsening after initiation of ATT, and we started the patient on oral steroids along with ATT. So on at 45 days of follow-up, we can see at presentation there was inferior sectoral congestion which had reduced. The swelling had also decreased on the neck significantly, and on consecutive visits after 15 days of presentation, we could see when the patient was on steroids and ATT, the disc edema had reduced, and even the ciliary body mass size had decreased significantly. On consecutive B scan and ultrasound biomicroscopy, we can see after 15 days of follow-up, when the patient was started on steroids, the size of the lesion had reduced, and even on ultrasound biomicroscopy, the size had reduced. Thank you.
Hello. Sir, you are muted, sir.
Unmute.
Yes, sir.
Now it's okay, is it?
Yes, sir. Yes.
Now again, a great case. Alok, great presentation. I think very well documented. I must say that it's not every day that we see the TB granulomas in the ciliary body. I mean, you see a lot of these in the Most of them are located in the posterior pole, the choroidal granulomas due to tuberculosis or sarcoidosis. Where here you have a unique young man who's asymptomatic. I mean, that is what is surprising to me. You probably then need to revise the criteria in Indian patients who claim to be symptom free, because a person who ultimately ended up having a disseminated tuberculosis, for which there was every indicator present. So somebody is saying that I'm not audible. Am I audible?
Yes, sir, you are audible, sir.
Yes.
So now, for instance, Monto's reaction. A negative Monto's is anticipated in patients, and if you are suspecting TB etiology and Monto's come negative, all the more reason that you need to look for disseminated tuberculosis, because in a disseminated TB, you will have Monto's reaction negative. Okay. Now, the surprising thing is the thyroid TB. You know, thyroid tubercular granulomas are reported, abscesses are reported, but these are exceptional. These are extremely rare. I don't think there are more than 100, 200 patients reported ever in the literature, and they feel that even in the disseminated tuberculosis, thyroid gland per se is not a favored site because of the thyroid hormone or the kind of vascular supply it has, or kind of colloidal material, or the excess iodine, which doesn't allow TB to set up infection in the thyroid. But then the availability of thyroid gland for fine needle aspiration biopsy is a great site to take a sample, which was done and which eventually led to the diagnosis, and you could demonstrate that. And if that were not available, there might have been, anterior cervical glands possibly involved, and one could have taken a fine needle aspiration biopsy. We have done from the axillary lymph nodes, we have done from the anterior cervical lymph nodes, and they have shown AFP positive. So rather than going to the lung to take EBUS or any such biopsy, if it is available outside the body, easily approachable, I think one would prefer that. Now, the point is, when the patient presented to you, you didn't know whether it's medullary epithelioma or was it a melanoma, or was it an abscess. So first tool that you do is use an ultrasound or a UBM in this case, and UBM would have certain characteristics. Okay, and typical hypoechoic, which is shown in your UBM, it's a very nice demonstration of a TB hypoechoic cavity, in your patient. So that's why it's worth reporting this kind of a patient. On the other hand, secondaries would be hypercellular. There would be, or malignant melanoma would be medium to low to medium reflectivity and echogenicity. So it will not show a hollow. The epithelioma, medullary epithelioma arising from non-pigmented epithelium, ciliary epithelium, would be hollow cavities, absolutely, not hypoechoic, but hollow cavities. And there could be single or multiple. Okay. And primary, now the most challenging lab test which came positive in your patient was thyroglobulin levels. Now, thyroglobulin levels in a 17-year-old is a young boy, okay, because thyroglobulin levels are associated with cancerous growth, okay. And whatever is my information, TB granulomas don't have that kind of thyroglobulin levels as your patient has, okay. So that is a very unusual, and one has to look up. I don't know the answer to that, but that could have led to a search. For instance, if your fine needle aspiration didn't reveal AFB, then you would be foxed for an answer, and you would be looking for, is that ciliary body metastasis from the thyroid cancer? Now, thyroid cancer, when it metastasizes, it doesn't metastasize that well to the eye. It metastasizes to other places, maybe the lung and liver, and primary metastasis to the ciliary body of the forehead would be unusual from a thyroid gland. Okay, so I think in the long run, what you have shown is again a paradoxical reaction, which makes it a unusual case, because paradoxical reaction we have failed to demonstrate in other phenotypes of ocular tuberculosis. We have shown it very well in serpiginous-like choroiditis, which is the best well known. We have not shown in retinal vasculitis or in granulomas, but people have shown in TB lymphadenopathy, mediastinal and other lymphadenopathy. People have used CT scans to show the size increasing after starting anti-TB drugs, which you are showing on UBM and other imaging modalities. You're showing the number increased, the size increased. So I think that's a very interesting to document that these choroidal granomas, and future people would be looking out, because they have not been looking out for paradoxical reaction in these patients with choroidal granulomas, or in this case ciliary body granuloma due to tuberculosis. But otherwise, I think I find it an outstanding case. So
Thank you,
Manisha
sir.
has seen, she writes that she has seen paradoxical reaction in granuloma cases, so it's great because granulomas are not very common, and they always indicate the presence of disseminated disease. And if Manisha has documented, I think it's very nice. It strengthens our case for paradoxical reaction in the ocular tuberculosis.